Good afternoon, everyone. First of all, sincere apology for not able to attend the conference physically due to my health reason. Today, I'm going to share with you point of care ultrasound in traumatic patient. Point of care ultrasound is not making you to become a radiologist, but rather helping you, assist you clinically. And it's not to replace stethoscope, but to assist you in day-to-day life. This is the framework of point of care ultrasound, which is mnemonic IM. What are you aiming for? Basically, I is standing for indication. The scan needs to be done for to answer a specific clinical question. A stands for acquisition of specific ultrasound image. And as you can know that this is a specific ultrasound image at a certain position. We're not going to become a radiologist to scan very detailed, but we want to do it on a specific images only. I stand for interpretation, which is based on clinical question. M is the medical decision making or the procedure. And these are 5 important areas that POCUS in trauma, where POCUS can help. First, traumatic brain injury. It can detect bleeding, midline shift, and edema. Airway to determine the endotracheal tube in place. Bone for any fracture. Eye for any sign of papillary edema and pupil size. And lastly, EFAS, which to scan for any bleeding in the abdomen or pneumothorax. Now let's begin with the case. Yep, this is a scenario. Yeah, a father brought 2 children come back from school. Right. Unfortunately, they made the accidents. The child at the back has suffered severe injury due to that. So, an admission, this is a 6-year-old child, billion driver, came into emergency department with a GCS of 7 with poor respiratory effort. He had difficult intubation because, as you could see, the face is as you can see here. The intubation was attempted 3 times. Has reduced air entry on the right side and poor saturation at 75 and constantly dropping. You're not sure is the endotracheal tube in trachea or not. Here, that's why point of care ultrasound can help you. So this is a ultrasound image of the vocal cord at the thyroid cartilage level. So this scan has been done at this position, and you could see that this vocal cord moving bilaterally. How to determine the tube is in place or not? So there's no tube in the vocal cord area. So as is shown here, the ETT is not in place. And if you could see a tubular structure here, that will reassure you the endotracheal tube is in place. So now after determining the endotracheal tube is in place, unfortunately the child desaturated further. Saturation was 60% and persistent reduced air entry on the right side of the lung. Is there any problem with the lung? Let's order a chest X-ray. But unfortunately, the X-ray will take some time. This is where point of care ultrasound can come very useful. So we're scanning the area of the lung. So this is the left side of the lung. Okay, you could see that there's normal lung field here. There you could see the sliding sign here, as you could appreciate here. But over the right side, there's no lung sliding in the upper zone, and there's a lung point over the lower zone area. This tells you that this child have a right-sided pneumothorax. So it's a rather easy and fast way to determine pneumothorax. Hence, you put in the chest tube on the right side. Saturation did improve. But unfortunately, you notice that the child become tachycardia and hypotension. And you notice that, and I mean, from what a physical examination that you can determine and conclude that this child has hypovolemic shock. But where is the bleeding? There, and the life-threatening condition due to trauma can be bleeding in the pericardia, bleeding in the lung, whether we need the bleeding or the pneumothorax like what the patient have, or intra-abdominal bleeding. There is a sequence of what we call EFAS, which is extended focus assessment of with sonography for trauma, whereby a sequences or algorithm of examination using point of care ultrasound in determining the bleeding in the abdomen and the thoraxes. This scan can be done very fast, but it should be performed within 2 minutes. We like Maggie Mee in Malaysia, it can be cooked within 2 minutes. So the EFAS examinations had to be at 2 minutes. So what the EFAS does is that they answer a focused clinical question, whether is there any bleeding or fluid in the heart, around the heart, in the abdomen or in the lung, or is any free air in the lung. So this is what we are looking for. Free fluid in the peritoneal cavity, pericardial sac or pleural cavity, or any free air in the pleural cavity. So E-FAST is basically useful for a patient who is unstable, which is cannot be transferred for a CT scan, unexplained hypotension, equivocal physical examination, or in patient, especially in adult, there's no detailed history due to drug intoxication, neurological injury, or mental shock. The other advantage of E-FAST is that there's non-invasive, rapid, portable, repeatable, and no radiation. Gone was a day that last time with the abdominal injury whereby people want to determine there's intra-abdominal injury or not. We used to do the peritoneal dialysis lavage. So with E-FAST, it has been replaced this invasive procedure now. But however, it should be emphasized that E-FAST do not replace CT scan. And these two imaging modality actually complement each other. So as we understand that in the patient lying involved traumatic injury, most of the time they are lying supine, and with the supine positions, the fluid will accumulated over the posterior aspect, as you could see, appreciate here, both right and left pala gutter area, perichoric gutter area, okay, and also at the upper abdomen and also at the pelvis area, because these are the area that forming a pond-like structure that allow the fluid to accumulate there. These are the important 6 sequences of E-FAST scanning, right? Starting from the pericardial, perihepatic, presplenic, pelvis, and both sides of the lung. And these are the area of the scanning that this E-FAST is doing. So let's start with the first scanning area, which is subcostal pericardial view. These views specifically are looking at the pericardial sac to detect any fluid accumulation around the heart. Okay, so this is a heart structure, right heart and the left heart. In a situation whereby there is pericardial fluid collection, as you could see here, right, you could see the fluid accumulated around the heart. The second view will be perihepatic view. This perihepatic view involves the probe putting over this side. You're going to see the liver, kidney, lung, and part of the abdomen. This is what we call this area, what we call a Morrison pouch, right? So if there is a positive E-FAST finding, you could see that the fluid will accumulate in the lung, okay, in the abdominal cavity, whereby there's a fluid-filled Morrison pouch over this side. Moving on, the third view will be perisplenic view. On perisplenic view, the probe will be putting on the splenic area. Okay, we could see the spleen in this position, the kidney, and also the lung. In the positive E-FAST scanning, as you could see here, you can see the fluid accumulation of the side, subdiaphragmatic, and also part of the lower abdomen. The fourth scanning area will be the pelvis area. The pelvis area, it can be sagittal view. So this is a sagittal view whereby you could see the bladder on this side, okay? And it also could be it can be rotated down 90 degrees and then looking at the transverse area. So this is the bladder and then this is part of the rectum. In a situation whereby there is a free fluid in the abdomen, you could see here, the bladder is full, right? And behind the bladder, by right, it's supposed to be free, but you could see that there's a fluid accumulated over this side. And this is a sagittal view. Similarly, you could see posterior fluid accumulation. Yeah. And also at the same time, you could see that there is some hyperaqueous structure in the bladder, which signify a hemorrhage in the abdomen, in the urinary bladder. And followed by both lung scanning that we had done earlier for this patient, whereby you notice the pneumothoraxes. So this child as a whole, we notice that he have a positive E-FAST, whereby there is a pericardial fluid collections, there's an intra-abdominal fluid collection, and there are also some free air in the thoracic area as well. So conclusion is there is positive E-FAST, meaning that the bleeding, the patient had intra-abdominal bleeding, right? Fluid resuscitation was done, blood product was given, a surgeon was referred, and the CT scan abdomen was arranged. And the nurses subsequently noticed that this child suddenly become bradycardia, relatively bradycardia, and become hypertensive. And you conclude that clinical examination, the child have Cushing reflex and impending cerebral coning. And you consulted the neurosurgeon. the neurosurgeon asks you, what is the pupil size of the patient? Is the pupil reactive? Is there any papular edema? By looking at this patient, you can't really examine the eye very well, right? So what point of care ultrasound can assist you? Point of care ultrasound can assist you to assess the pupillary response. As you could see here, if the patient have one-sided eye injury that you cannot open over this eye of the eye, you can do a indirect light reflex. Okay, with the indirect light reflex, the light will shine onto the eye that can be open. You could see that you can, by using the point of care ultrasound, you could see the pupillary reaction over this side. So if there's a non-reactive pupil, the pupil size will be fixed. But how about this patient? Our patient who have both eye cannot be open, right? If the both eyelid cannot be open, what we could do is that we can persist, we can do the eye ultrasound examination, but we inflict pains. With the infliction of pains, the pupil will dilate. So if the pupil is not dilated with the pain infliction, meaning that the pupil are fixed and dilated. Not only looking at the pupil size, point of care ultrasound can assess indirectly to looking at any sign of papular edema. So this is the normal anatomy of the eye. So in a situation that where you have papular edema, the CSF fluid will leak, will shift into the arachnoid space around the orbital nerve, right? So with the back pressure will cause the optic disc to be bulged up. So what are the important signs that it can elicit with using point of care ultrasound to see the eye changes in papular edema? So these are the 4 signs of high ICP or papular edema in terms of MRI finding. So you could compare here is a normal MRI finding. This is a patient with high ICP, right? First of all, you could see that there is optic disc elevation. Yeah, the optic disc elevation as we discussed earlier. This is a smooth optic disc, but this is elevation of the disc. Second, posterior lobe flattening, whereby you could see that this is a very nice lobe at the back, circular, but over this side, because of back pressure, it's pushing forwards the eye globe. So that's why you have posterior globe flattening. And because of the sipping of the CSF in the along the optic nerve, you could see that the CSF presence around the optic nerve that increase optic nerve shift diameter. Here is normal. This is increased optic nerve shift diameter. And the optic nerve will be going to become tortuous. Why become tortuous? Because there is a fixation over the eye and also at the area of the bone. With the seepage of the CSF into the optic nerve, will create pressure and subsequently make the optic nerve become tortuous. How about the ultrasound finding? So this is the ultrasound finding that you could see here. So in the ultrasound finding, you could see the optic nerve elevation here, right? So similar to the MRI finding. Posterior globe flattening, yeah, it becomes flat already, no longer a round shape. And here you could see the increased diameter of the optic nerve shift. And also concomitantly, you could see that the optic nerve is no longer straight, it is a tortuous, right? Not only that, the point of care ultrasound can also tell you if there's a severe cerebral injury, okay, even the eye can get traumatic. So there is an elevation. This is what we call a retina detachment. You can diagnose using an ultrasound. And also retina hemorrhage, as you could see here. So with all the finding, you notice that this child have increased intracranial pressure. Hence, you use 3% normal sign was given and heart rates improved. But the other question is now, what is the blood pressure to aim for adequate cerebral perfusion? As you could see here now, the blood pressure is 90/40 now. So by looking at the cerebral circulation, point of care ultrasound can also detect, can study the cerebral blood flow. Yeah, because the cerebral perfusion is important for us to manage patients, especially when they have increased intracranial pressure. So there are small little bone in the skull structure, right, which is the thinnest area. The squamous bone area or the temporal squamous bone is the thinnest area. So these are the small window that you can see through the bone, right, by using the ultrasound scanning, as you could see in the video here. So what we're going to study is that the medial cerebral artery here, which is supply 60 to 80% of blood circulation in the hemisphere. From that scanning study, you can know the cerebral blood flow, the Doppler cerebral blood flow, yeah, and from there you can conclude and do some calculation, by looking at the flow velocity, okay, and there's some indices for the arterial resistance and the flow direction. So what does it mean in clinical practice? Okay, so for example, we have a patient who have consistent blood pressure of 70/35. Okay, for the young patient 70/35, and this is a relatively ICP pressure. So if your ICP pressure is 5, the cerebral circulation in the brain will be 65/35. Right? So this is the pattern of the blood flow or the pressure in the brain uh, can be studied by using this kind of graph pattern, right? And if the ICP become increased, okay, the blood that able to go into the brain is only 55/10. So that make the graph change into this kind of pattern. The blood flow velocity in the brain become this pattern. So if the ICP increase further to 35, so you're going to lose the diastolic flow into the brain, whereby the cerebral blood circulation will be only 35/0. Hence, the blood flow pattern become like this. So if the pressure, intracranial pressure increase to 75, so now you have the problem of reverse circulation, right? Because the pressure in the brain is too high. During diastolic pressure of 35, right, you're going to get a reverse flow. So if the pressure increase further, right, the diastolic reverse flow is going to be increased further. So all this kind of flow pattern, okay, this signifies the pressure can be studied using the cerebral Doppler. As you could see here, so these are the different pattern of the blood flow study that you could see here. So nice flow, relatively loss of diastolic flow, okay, and then the diastolic flow pressure is relatively equal to the ICP pressure, and then you got reversal flow, and the flow becomes subsequently diminished due to high intracranial pressure. So from here, you can roughly know that whether your pressure, the cerebral pressure in the brain, cerebral circulation pressure in the brain, whether it's adequate or not, even without ICP pressure monitoring. So this is the patterns, okay, as we had known just now. So in a normal situation where the cerebral perfusion pressure is reserved, this kind of pattern will show during the cerebral Doppler study, and subsequently it deteriorated further, right? And in the situation whereby there is impending cerebral circulatory arrest, this is the pattern that you're going to see, right? So not only that, if you have a good window, especially in a smaller child, okay, you can actually see any fluid accumulations. Oh, this is the child with a subdural bleeding, right? And you could see that there's a midline shift. This is a corresponding MRI finding, right? But this we require a good window for the ultrasound study. And similarly, this child, the same child, by doing a transverse view, we could see that there's a significant accumulation of the subdural hemorrhage here as corresponding with the MRI finding. So this is ultrasound finding. So, yep, so now you notice that blood pressure probably is not so enough to sustain the cerebral perfusion pressure. You started some vasopressin to ensure the cerebral perfusion pressure while awaiting CT scan. And during examination, you notice that the right forearm is slightly deformed, as you could see here. Now, the question up to you now is that, is there any fracture in this child? So point of care ultrasound can actually assist you to identify a long bone fracture. So this is a normal long bone. You could see that there's continuity without any disconnection. Okay, so this is a nice bone without any fracture. So here you could see that there's a discontinuity on the fracture or disruption over the nice long bone. Okay, so you conclude that, oh, okay, this limb over this side, there's some fracture over that area. So this concludes POCUS in trauma. So it can help you in traumatic brain injury, airway, bone, eye, and EFAS that, to detect any bleeding. One must know the limitation of the point of care ultrasound. And to remember, it is very operator dependent, machine dependent, and also it is also very much depending on the acoustic window that you could see the area. Okay. With that, I thank you for your attention.